Right. Well, so many people actually rallied around this barometer. Jean-Marc Tourani in Poitiers, Roland Bugat and Marie-Ève Roger Bugat helped develop a lot of actions in the southwest of France. Our other colleague around Lyon, Nicolas Jovan, who was more in the northern part of the country. Our colleague from Nice, who was in charge of the southeast, Christophe Tournigan, and Ivan Karnowski. So, if that's agreeable to you, I'm going to ask Marie-Ève to join us. And if some others want to come back, Marie-Ève doesn't want to come, so that we can have a discussion all together. Do you have any questions? Well, I'd like to ask a question to David Waugh. Would the mask be interested in conducting such a study on an international scale to try and find out more about what practitioners, what doctors think and what patients think?
Question, because MASK is a global organization with a large number of study groups, but we don't have one that encompasses everything you've put in there now. And so our surveys have been very much symptom focused. I think it's an option for doing that, but it requires champions such as yourself and a proposal to come forward for some funding. We have to partner with the pharmaceutical industry wherever possible to do that. And I think it would help to get out the idea of supportive care being from initial diagnosis to the end, increasing awareness of that, because I think many people equate supportive care with just end-of-life care, and that leads to under-treatment, as we heard from Matti Apro, for preventing febrile neutropenia. So I think that's a good idea. It's just a matter of how do we come forth outside of one study group, and it could be a multiple group proposal for that, and we can certainly act on behalf of the groups to try to get industry funding.
Avez-vous des réactions?
Any responses? You must have something to say in response. There has to be responses. We spent 3 hours with journalists on Tuesday morning, and there were lots of responses. Don't do this to me. You have to have responses to this barometer. What do you think? Woo. What do you think the nurse who first tells the patient about their cancer treatment, what do you think their role should be? The figures that I showed, did you find that in your clinics?
Are very interesting and are perhaps surprising in certain instances. The mismatch between oncologists or doctors and patients is not surprising, but something useful. I would think that MASK or someone else could conduct this using something like SurveyMonkey very inexpensively. And as David said, we need a champion or a few champions to do it. And it should be sent to much more than just the MASK membership. Where you would find registers for this, I'm not sure. But it would be extremely interesting to see differences among countries. And I think that it would be good to get a panel together to see which questions you wish to focus on. I think you should reduce the number of questions when you make it a very broad survey, but that this could be done for extremely little cost. And so I don't think that we would necessarily need to go to pharmaceutical industry to fund this. Again, through various web-based areas. The difficulty would be to get the list. It would be good to do it among professions. There are oncology professionals in pharmacy, in nursing, in medicine, and in different medical fields. I thought it was most interesting to see the primary care physician difference. That is something I've not seen before, and I think that would be interesting from different countries and would speak to the communication issues that you mentioned. One would think, as we move towards electronic medical records, that communication can therefore be more automatic. Whether that will actually occur or not is a different story. But I would think that forming a basis of such a study and then planning to do it again in 2 or 3 years would be very interesting. So I applaud this beginning. I think that it should be a very interesting thing to pursue.
I think an important way was that we asked for residents to and fellows to ask patients what about supportive care, and it had 2 aspects. First aspect to get information from what about supportive care in your establishment, and the second aspect was I'm involved in supportive care and I will ask for patients about supportive care. So I'll think about it and I will try to develop supportive care in my institution. So electronic way is an important way, and it's more easy for a large survey, but probably the impact of the teachers and to use the residents and the fellows is important to teach them what about supportive care and to talk about supportive care to patients.
That's a different goal. Teaching is a different goal, an important goal, but a different goal.
Okay, so
Florian, I was wondering, did these residents carry out this work just out of the goodness of their heart, or did you have to offer a minor incentive to them? And a second unrelated question is, it looked as though in about 30% of facilities there was some expertise in complementary and alternative medicine, or did I misunderstand the question?
So your second question, for the residents, they earn some money. It was around, je ne sais plus.
Yeah, they were incentivized.
Yes.
Good.
So they're like North American residents, yes, incentives.
It's because Ospira was here to help us to perform this survey.
In your survey, in terms of the facilities or expertise in supportive care or services in supportive care, it looked as though 30% said that there was something in the area of complementary and alternative medicine.
Yes.
Is that correct? Because that's not in the typical Canadian model, certainly.
It's the answer. Yes, it's correct, but it's the answer that we have. It's very interesting for to get this information. We have to work on it.
Je voulais rajouter une remarque.
I wanted to add a comment. It's true that there was the initial experimental phase in our hospital towards the end of 2012. There was a report with a number of guidelines. And this year, there was a renewed call for tenders to renew the second phase to have an organization spearheaded by the hospital, but also other projects besides that, with actually self-employed nurses and health professionals. And I thought that would be a good way to improve transmission of information. And because you mentioned the necessity to pass on information from the hospital to the private sector, but I think it can go both ways. And I wanted to add that 10 projects will be financed during that second phase of experimentation, and I think the deadline was today to apply. It's always like that, isn't it? And the findings of that barometer will be presented at the AFSOS symposium in a month from now. And on the 5th of December, we want to develop all these findings some more, so you can, pass on the message. On all the people who are involved in the barometer will be here. I didn't see anything about patient associations, and they're very active in supportive care, in passing on the information, in fostering a link between hospitals and communities. That's true. We had a very long list of stakeholders, and we had to make a number of modifications to the 2010 barometer. So in the future questionnaire, in early 2016, we definitely made a note of that. So thank you for your comment. Thank you, Florian. Well, you're preaching to the choir here. I wanted to mention a specific case of hematology because I saw that there were a lot of responses from hematologists, and I heard what the resident said when he interviewed patients. Seems to me that for them, treatment is a whole. I get there and I get my treatment. So it seems to me that there's no distinction between the endoxin tablet, the antiemetic, the GCSF. It's all part of a whole to them. And after all, do we really need to harass them, saying, well, you need to separate things. You have chemotherapy and then you have supportive care, because they just want to be cared for. So, which might explain the difference between the medical questionnaires and the doctor's questionnaires. But when patients defines palliative care, there's a confusion between palliative care and supportive care. So that would be interesting to discuss some more. Yes, indeed. That's a very important and apt comment. Definition of palliative care is very surprising. And when we looked into the findings, what surprised me even more was that I saw exactly that definition for palliative care in other sources. So that's real life, supportive care. Well, we have to be careful because for our North American colleagues, supportive care is not exactly the same as what we mean by it. So, and then when we translate it in French, soins de support, which is the literal translation, is a bit meaningless. So, and the president of the association gave a definition, so we can't really question that. But I think we have to work on a definition that has no derogatory connotation. But communicating is absolutely essential. And distinction between supportive care and other specific treatment, that's important, I agree with you. But having said that, you still need to inform patients about the therapy. When you give them a treatment, to improve and prevent adverse effects of radiotherapy, you can't give a treatment without explaining everything else behind it. And it's exactly the same reaction. It's thought-provoking when we think of what happens when the patients are first being told about their cancer treatment. There's a gap, in the different hospitals between, what is requested, what is required, and what really happens in terms of patient information. And I think there's really a problem with the role of the nurse, who's supposed to be the one explaining the cancer treatment to the patient. And patients say that 75% get it from their oncologist.
And supportive care definition, an early speaker, put up the MASK definition, and I think it's a wonderful definition. And I, 6 or 7 months ago, looked up these definitions by different organizations. You find that the definition of palliative care is changing and is moving toward the MASK definition. And you find that from many organizations. You find that many palliative care organizations have no definition of what is palliative care. And so maybe it's a semantic issue, but MASK means everything essentially other than the treatment of the cancer itself. And certainly you find many people look at end-of-life care for palliative care. The questioner a few minutes ago said, shouldn't this be part of simply the overall care of the cancer patient? The answer is, of course it should. That is absolutely correct, but unfortunately it does not seem to be. We educate fellows, at least in North America, more on bone marrow transplant than we do on supportive care, and more formally. And so it is an issue. Last year at the TAO meeting, Eduardo Bruera from MD Anderson gave a survey at MD Anderson that he reported on to doctors at MD Anderson. Would they be more likely to refer patients to a palliative care expert or to a supportive care expert? And by far, it was to a supportive care expert. So there are connotations, there are perceptions that are important. We don't need to have disagreement. We need to understand and support the fact that there needs to be care beyond the choice of a chemotherapeutic agent. In fact, it should also be said that the choice of a chemotherapeutic agent is really not so very difficult very often, that too many people depend on guidelines which they use as a cookbook, and that is really careful. When you described prescribing laxatives at the same time as you prescribe pain medicines, it's very simple for me to prescribe a pain medicine, but it takes a much longer discussion to teach the patient as to how to use laxatives. And so I think that there are a lot of things that are missing that we need to do better on.
Je vais le faire en français.
I totally agree that the definition given by the MASK, by Jean Glaskowski's team in Brussels. Here in Paris, we're very close to Brussels on train, and New York is much further away, but having said that, it seems that the definition reached New York earlier than it reached Paris. And the definition of supportive care, actually, that definition dates back to 2005, and it took a long time before it reached France. it was used for palliative care for people who were dying. So I think we have to recognize the specificity of the teams looking for people who are dying. If we forget about that, we'll go back 30 years in the past with the same, lack of understanding of the whole role of supportive care. And I think that's what the mask promotes. And also the AFSOS, it's precisely that, is to really claim that that global care given to patient, and that was developed by palliative care, but it has to start as soon as possible after the diagnosis, but patients fail to understand that. So quite often in France, they just confuse. They're a bit confused. They don't know what it means. So is it supportive care? Is it palliative care? And palliative care kind of hides, occults what should be supportive care. So I think health professionals also maybe don't use and inform enough on the term. Mario, I think all the things that have been said are very apt, but in the general opinion in the medical teams, everything's palliative. They don't make the distinction between palliative and supportive care. So I'm very surprised by those very good answers you got from GPs, because I'd be surprised if it were the same in our teams. But GPs did say that palliative care to them are fairly similar to supportive care. But even so, I mean, the degree of awareness was fairly high in your answers. And in Belgium, for example, and in many other places, palliative care is actually administered by anesthesiologists. So it's completely different. So if you want to conduct a European survey, you need local champions, because otherwise it's not going to work. Because healthcare systems are different, reimbursement systems are different. And for example, in Belgium, we do not have those nurses you mentioned that are supposed to inform about cancer treatment. Well, if we conduct an international study, we cannot use such a questionnaire because it's too long. And it would take too long to fill it in, and there were a lot of questions that were fairly specific to France, so we would have to adapt it to an international scope. But I think it would be really interesting to have that kind of insight and that kind of observatory to find out what's happening in all the different countries. And in terms of definition, if only in terms of definition, it would be really interesting to find out what people put behind the word. Another remark about complementary care, I think it was 30%. 30% is I think underestimated. In Switzerland, it's way over 50%. You may remember in Evian, our colleague de Saint-Gall had presented a study about Switzerland, and it was over 50%. That was just a comment. Well, okay, in terms of complementary care, to pick up on what David said, that's a questionnaire that was actually conducted amongst residents, and some of them did not want to say more, so that might have limited the responses.
Encore une dernière, parce que...
One last question? Yes, good evening to all of you. I have a quick question. They say that palliative care starts when there is no longer any specific treatment for cancer. But in that's the theory. In reality, patients who are under palliative care still have chemotherapy or radiotherapy to help with pain. And those two treatments can cause adverse effects, which means that we need more supportive care, and it's a vicious circle. More palliative care, more supportive care, and I find it difficult to answer the patient when he asks me, "Is that palliative care?" Because yes, you are benefiting from palliative care, but there will still be supportive care that you need to get. So it's hard for us to make the distinction. Well, yes, it's a question of semantics, but only it's a question of each and everyone's role. In France, the talk about supportive care was that people who were in palliative care thought we were going to steal their jobs from them. So we have health professionals that are experts in cancer treatment. We have experts at each link of the chain, and they need to learn to work together. So we have to define the roles of these people in the care program and have a continuum, have a good coordination, because that's a must. We all need to be patient-centered, and it has to be very cross-disciplinary and cross-cutting, but that's in my opinion.